Dr. Vinay Prasad from MedPage Today. I'm joined by Dr. Chul Kim from Georgetown University and Dr. Andrae Vandross, and we're talking about lung cancer. So one of the scenarios that happens a lot in lung cancer that we don't talk about explicitly enough, that I'm very curious what these two gentlemen think, is the situation of a newly diagnosed patient where you've sent out genetic testing and you're facing that treatment dilemma right now. So here's the scenario so often happens. A patient gets admitted or a patient comes to clinic and they are diagnosed with non-small cell lung cancer. You have a clear sign on CT or PET scan. They have metastatic non-small cell lung cancer. They may even have some small brain metastases. And you sent the tissue for genomic testing. But you know what? This genomic testing, it needs to be like door to balloon time. It needs to be a quicker turnaround, but it isn't always. And sometimes it takes weeks to get it back, 3 weeks. So I think there's an interesting second order effect that happens. If the patient in front of you is a young female non-smoker, young male non-smoker, you know, your hope and your optimism that they have a druggable alteration goes really high. And your perhaps reluctance to give chemotherapy while you wait also increases. How do you navigate this space? You might do them some disservice actually by delaying treatment. Dr. Kim, how do you think about this dilemma? The person in your clinic, this isn't the 75-year-old smoker that you're not very optimistic about. Let's say this is a 50-year-old non-smoker, new diagnosis non-small cell lung cancer. They got a lot of disease, and you send out the genetic results. You don't have them yet. How are you thinking about this patient?
Right. So lung cancer in many times can progress quite quickly. Some are more indolent, some are, really aggressive. And so I look at patients, how symptomatic they are, and what's the burden of disease, as you mentioned, Dr. Prasad. And then in my practice, I send tissue NGS, next generation sequencing, as well as circulating tumor DNA. If I have a patient, like you described, young patient, no smoking history, likely to have a very high chance of having a mutation that are targetable. The benefit of doing circulating tumor DNA is that the turnaround time is pretty fast, about 7 to 10 days time period. So, and many patients can wait another 7 to 10 days before we make the final decision. If the patient cannot wait and needs to get treatment right away, what I do is I give them chemotherapy without immunotherapy. Because the challenge, if you start the patient on immunotherapy-based treatment, and then the next generation sequencing shows some target mutations, say EGFR, then you are you have a hard decision to make, because you can start, yes, TKI, osimertinib, other drugs, but then the rate of side effects goes quite high if the patient is receiving immunotherapy and they are starting TKI. So I tend to use chemotherapy alone in this kind of situation. If the patient needs chemotherapy, cannot wait for the results of NGS.
Yeah, I agree with you, and I tend to do that. And I actually think my suspicion is we don't do that enough, actually, that we are actually in equivocal cases, we're more likely to wait than we are to just give a cycle of carbotaxol or something like that while you wait. And I wonder if this is actually like a ripe place to do a study of what to do while you're waiting for the genomic results. It's either that or find a way to get them done faster. And I always say that time to pathology report should be a new metric, because I want to see that metric. Dr. Vandross, how do you think about these situations? They happen not infrequently, and they're more and more these days. You have that patient that you're worried about, when you decide to pull the trigger on a cycle of chemotherapy while you're waiting for these NGS results.
I'm telling you, the anxiety that came up as soon as you mentioned this scenario, it just goes through the roof. And that's just me. I mean, just consider the patient. I don't have much more to add based on what you guys just said, except to the fact, just to highlight this, it is a very serious issue. I do think that a study would be very, very helpful in terms of strategies and being able to counsel patients appropriately to know that, okay, yeah, we're going to send NGS. We have a high likelihood or a low likelihood that it's going to yield an actionable mutation such that you'll get osimertinib or something similar. But in the meantime, based on the clinical status and their level of comfort waiting, we're going to give a cycle of chemotherapy. Because, one of the issues that always for all of us is when we're assessing a patient, they look great. They can look great. But one thing that I've learned over time is that sometimes you don't know how close to a clinical cliff someone's standing. And that's really, really distressing to me sometimes. Those are the things that you sort of wake up and stay awake at night about.
That's funny you say that, because that's how I feel. And those are the cases that haunt me, are these choices. And they really do haunt me. And I regret and I think about how I could have done better. And I think one of the challenges here is that makes this really complicated is that the younger they are and the more they fit the phenotype of driver mutation, the more you are optimistic and willing to hold off a little bit. And then as you get into the brain met space, you know, if somebody has some small brain mets and you think they're EGFR positive, you're going to think Aussie's got good blood-brain barrier penetration, and you're not going to want to pursue radiation or something like that. But there's not 100% chance they're going to come back with an EGFR mutation. And you're letting brain mets sit idly for potentially weeks while you're waiting for that. You know, and those are the cases I agonize about. And I think you put it well. You don't know how close to a cliff someone is. And we've all had the experiences of while, you know, you thought somebody could make it there and something unexpected happened, such as even DIC or even some really profound catastrophic thing, brain bleed. Dr. Kim, any more thoughts on this scenario? I really think it's an under-discussed space, this anxiety.
Right. I think it is important to act, and if you have to give a dose of chemotherapy, I mean, that's my approach. You know, for patients who are waiting for the molecular testing results and are, you know, have really high burden of disease and really symptomatic. And so I think it's important to give the timely treatment to patients, you know, be it chemotherapy, be it TKI, because timing of treatment sometimes matters quite a bit.
Yes, that's well put. Well, my closing thoughts on this are we're very interested in oncology and looking for more genes and more cancers. But what I'm very interested in is the genes I want to know about, faster. And that's my interest in oncology. So Dr. Kim, Dr. Vandross, thank you so much for that.